Hi, today's lecture is actually just a revision on certain important drugs that we use and the cardioselectivity of those drugs. Okay, so first of all, we need to understand beta 1 and beta 2 effect, beta 1, beta 2 receptors and their effects. And then we also need to understand where dobutamine, doputylide, phenylephrine, uh, dopamine, epinephrine, what will they possibly cause? Okay, so first getting into the very basic part of it, what basically is the selectivity. Okay, so before I get into the receptors, just it's important to note that dopamine has D1 selectivity greater than B1 selectivity greater than alpha 1 selectivity. Epinephrine has alpha 1, beta 1, beta 2. Okay, dobutamine has beta 1 greater than alpha 1. Okay, which might be equal to beta 2. So when you talk about dobutamine, you want to think only of beta 1, because alpha 1 and beta 2 might just cancel out each other when it comes to the blood vessels. Then we have something like an isoprenaline. Isoprenaline is a beta 1 equals to beta 2. Okay, then we have terbutaline, or something like a salbutamol, which is more of beta 2 greater than beta 1. Okay, and then we obviously have the much acclaimed norepinephrine, which is more of a vasoconstrictor. You can think in those terms. So that's why alpha 1 is equals to beta 1, which is far greater than beta 2. Okay, not far greater, but just greater probably. Okay, so these are just an important sets of uh, preference that each of these drugs follow should be kept in mind. So I'll just go around it once more. Dopamine is D receptors. Dopamine receptors obviously first, then beta 1, and then alpha 1. Norepinephrine is more of a vasoconstrictor, always remember. So alpha 1, beta 1 is better than beta 2. Epinephrine is all of them, alpha 1, beta 2. So it's a good drug. Dobutamine is beta 1 way more, so it's going to increase the heart rate, always remember. Isoprenaline is beta 1 equal to beta 2, so does not really matter. It will increase the heart rate, plus it will increase the GG, plus it will also increase the vasodilation. Terbutaline is beta 2 greater than beta 1, so it's a smooth muscle relaxant. These are just like a very important overview, because most of the questions that are asked in UWorld is based on the fact that the preference and the dosing and at what level what effect is seen. Okay, so I guess that is something that is sorted. Now let's just understand what is the effect of epinephrine compared to norepinephrine compared to isoprenaline on vasoconstriction, on heart rate, on the blood pressure, on the systemic blood pressure, on the diastolic blood pressure, all of them. So let me just write epinephrine, then norepinephrine, and isoprenaline. As I said, beta 1 equals to beta 2. First, let me write them down. Norepinephrine is alpha, because it's a vasoconstrictor, alpha 1 equals to beta 1, which is greater than beta 2, as I've said. Okay, and epinephrine is all of them. So alpha 1 equals to beta 1, which is equal to beta 2. Now, first thing we need to talk about is heart rate. What is going to happen to the heart rate of this entire scene? Correct. Uh, it's pretty simple that to understand heart rate, we need to also consider blood pressure, because usually blood pressure actually monitors heart rate via the carotid baroreceptors and the aortic baroreceptors. So first we need to understand the BP. So I'll write the BP here. Okay. Now in BP we need to understand the systolic blood pressure and the diastolic blood pressure. Now you tell me, because it is an epinephrine, what's going to happen to the systolic blood pressure? It's going to increase. What about the diastolic blood pressure? Is it going to increase? Is it going to decrease? It's going to increase in slow infusion. Now the reason being that the alpha 1 might just actually cause vasoconstriction, and then we need to understand what will happen to the mean blood pressure, which is going to increase because both of them are increasing. So let me write a double increase out here. Now the heart rate first of all is going to increase, okay, but reflex is also going to occur. So reflex is going to occur because of the vasoconstriction, but the reflex cannot actually undo the beta 1. So in the end the heart rate is increasing. Now let's come to norepinephrine. Norepinephrine is alpha 1, so you will have a and a beta 1, so you'll have a strong vasoconstriction. A strong vasoconstriction, a mean blood pressure is going to be high. Now your because it's such a high mean blood pressure, the reflex is also going to be pretty strong. So you'll have a single increase in your heart rate, or a double increase in your heart rate, does not matter, but you will have also a very significant reflex bradycardia, and because of that you will have a decreased heart rate. Now what about isoprenaline? Isoprenaline is again increased systolic BP because of the but it's pretty much normal actually, and the diastolic blood pressure is going to decrease, the mean blood pressure is decreasing, so your heart rate is eventually increasing. Why? Because of your reflex tachycardia plus the normal beta 1 effect that iso can have. Now this is just also another very important concept that we've kind of cleared at its roots itself. Now coming to the various sympathomimetics. Now as I said that epinephrine is going to stimulate all of them, alpha 1, beta 2, beta 1, all of them. So where are you going to use epinephrine? Well, epinephrine is going to be used because of its beta 2 property as a vasodilation, as a vasodilator, plus more than that as a bronchodilator. So you're going to use it for anaphylaxis, simple as that. Okay, and it's a potent cardiac stimulator. Why? Because of a beta 1 and beta 2 effect both. All right, so it's a potent cardiac stimulator, so epinephrine you want to make sure you give them. And that's one concept that we've got out of our way. Second is something called as a Dale's phenomena. A Dale's phenomena is basically when you give epinephrine, what happens to the BP. And when you give epinephrine, your BP is going to rise, right? But then you give an alpha, okay, so when you give epinephrine at a low concentration, what is it going to prefer? Okay, at a low concentration it's going to prefer the beta, okay, at low, but at a higher concentration it's going to prefer alpha at a higher concentration. So what happens is that when you infuse epinephrine, you're infusing epinephrine at a higher concentration. Because of that, your alpha 1 is going to increase and your blood pressure is going to increase. But when the concentration falls, this is the concentration, okay, this x-axis is the concentration, and as the concentration falls, you can see that yes, your beta 1 is actually your beta 2 is going to fire, beta 2 at lower concentrations. So that is one important parameter that should be taken care of. Another very important point that I wanted to make was that dopamine has a different action at different concentrations. Again, at something like a point 0 to 2 you would have a microgram per kg per minute. It would be something on a D1, but from 2 to 10 you would have it on a B1. As I said, it's going to be D, which is greater than B1, which is greater than alpha 1, as we've seen out here. Okay, so DBA for dopamine. All right, so that is one very important thing. Dobutamine, as I spoke about, is again beta 1, so it's greater than beta 2, so it's actually going to increase the heart rate, and it's something that you can use for heart failure. But again, if you're using it for heart failure, you should keep in mind that you should not be using it for an MI or even for an transmural ischemic attack, because increasing the heart rate is going to eventually deplete the blood supply, as the blood supply and the coronary flow and the coronary blood supply is dependent upon the diastolic time. I hope you know that when the diastolic time increases, the coronary blood flow increases. So that's very important in maintaining coronary blood flow. Then we have something called as a phenol dopam. interesting. And then we have something called as a dopexamine. No one cares about this dopexamine. Just to let you know, it's a D1 and a B2 stimulator. D1 and a B2 stimulator. You can figure out what would be its use. D1 because beta 2 is going to increase the heart pumping. That's about it. But again, you're not going to use it. Phenoldiazepam is something that you should remember. It's alpha receptor, alpha 2 positive, and a D1 positive. Now for the first time, your alpha 2 has come into the picture. So far, alpha 2 we were kind of not even thinking about it or not even talking about it. So now what does alpha 2 actually do? Think about alpha 2 as a GI. It's a GI receptor. So alpha 2 is just going to cause what is the opposite of alpha 1, because alpha 1 is a GQ receptor. So what happens is that if there are nerve endings and of the sympathetic ganglion and going to a vascular smooth muscle, and there are alpha 1, so the simple thing what the body does is it very simply has alpha 2 receptors around uh, at the presynaptic area, and the alpha 2 is just going to decrease the firing of the sympathetic nerves, or your alpha 1 receptors. If it is present at the muscle, alpha 2 it's going to inhibit the muscle. Okay, it's going to cause decrease action of the muscle. So in some way or the other, it decreases norepinephrine release as well. So decreases norepinephrine release, and by that it's going to cause the increase in heart rate. First of all, because of its, as I said, because of its D1 action, it's going to cause increase in diuresis and decreases BP, because D1 is a diuretic, dopamine, and it's also going to decrease the blood pressure. And that is something that had to be spoken about when it came to this entire scenario. Anything else? Okay, clonidine should be covered. Why? Because clonidine is one drug that is quite interesting. It's associated with a lot of down regulation, and it is used for hypertension. Why? Because it's an alpha 2 stimulator. Now just think about it. As I already spoke, that's the entire scenario. It can be used as hypertensive, it can be used in Tourette's, it can be used even in ADHD patients. But the thing is that you will have a side effect which is called as a withdrawal hypertension. Why? Because your alpha 2 receptors will be down regulated. When you increase the use of clonidine, think about it as tolerance. So you'll develop kind of a tolerance, and these will be down regulated, your alpha 2. Now when your alpha 2 is down regulated, you know your blood, your presynaptic neurons, they, no matter how much of clonidine do you give, it does not matter, right? So now when you stop giving the drug, normal amount of epinephrine cannot even inhibit this. So for that, you will have another hypertension because your alpha 2 is not working. And I think that is about it when it comes to the selectivity of receptors. Obviously, we've got your beta blockers and stuff like that. So very important to know is that when you're talking about a beta blocker, Mabeb is one important consideration as a cardioselective. Mabeb basically metoprolol, atenolol, all of those. And I guess that's about it.